Hello, I'm Dr. Glenn Eisen. I am the Editor-in-Chief of Gastrointestinal Endoscopy, and welcome to our author interview series. Today I'll be interviewing Dr. Rahul Pannala, who is currently an Assistant Professor of Medicine at the Mayo Clinic in Scottsdale, Arizona. We will be discussing his paper, Afferent Limb Syndrome and Delayed GI Problems After Pancreaticoduodenectomy for Pancreatic Cancer, a single-center 14-year experience. Of note, this paper is a study based at Virginia Mason, where Dr. Pannala did his advanced fellowship. Dr. Pannala, welcome.
Thank you for having me.
How are you?
I'm doing good.
So can you tell us the genesis of this study?
Yeah, we see a lot of pancreatic cancer patients, and while there is a lot of data on what happens to pancreatic cancer patients following surgery, there's very little information about what are the complications, the delayed GI complications going forward. And as our treatment for pancreatic cancer gets better, more and more people are surviving longer. And so we were interested to find out what the problems these patients are facing, and we were specifically interested in detailing the issue of afferent limb syndrome in these patients.
Okay. Now, some of our readers might not be familiar with afferent limb syndrome, so could you define that for us?
So afferent limb syndrome was originally described in the post-gastrectomy syndromes, which we used to do for peptic ulcer surgeries. But in pancreatic cancer patients, when they undergo a Whipple operation or a pylorus-preserving pancreaticoduodenectomy, some patients run into a problem where there's mechanical obstruction of the afferent limb, either due to radiation or due to recurrent cancer, or due to a mechanical kinking of the afferent limb, which results in obstruction of the pancreatobiliary system and consequent cholangitis, abdominal pain, nausea, vomiting.
So how large a cohort did you collect for this study, and what fraction ended up developing this complication?
So what we did was went back and looked at our institution's experience over the 14-year period. And to keep it a very homogeneous study population, we selected only patients who had surgery and follow-up treatment at our place. So overall, we had 186 patients. And among the 186 patients, about 13% developed afferent limb syndrome at a median of about just over a year.
What was the overall survival of this patient cohort? Because as you said, it's very rare that patients have an excellent survival after treatment of this cancer.
Right. We did not calculate actual survival analysis for this cohort, but historic data from our institution, from other papers, is an actuarial survival of about 44% at 2 years, and or actually 61% at 2 years, and about 44% and somewhere between 2 and 5 years. Patients at Virginia Mason are getting a very intense chemoradiation protocol, and we were interested in looking at these problems when patients are exposed to this such an intense radiation.
And is this the type of complication that you can anticipate, or do you generally wait till the patients become symptomatic?
Usually it's something that once the patients become symptomatic, they're usually present with obstructive jaundice, nausea, abdominal pain. The times when we can anticipate it would be in a surgical complication or a surgical technique related issue where there was problems with constructing the afferent limb, okay. But those are few.
And can you discuss the endoscopic successes and failures of treating this complication?
So one of the important things that we wanted to look at was whether endoscopic interventions are effective, and typically the traditional way to treat this has been either a percutaneous drainage or repeat surgery, and both are problematic in this patient population. So what we describe is about 2/3 can be treated endoscopically and effectively, and about 3/4 of the patients who were treated endoscopically, the combination of either balloon dilation, double pigtail stent placement to try to facilitate drainage of the afferent limb, or in occasional cases metal stent placement, the patients improved clinically and biochemically.
Were there any predictors of endoscopic failures?
Yes. The most important, in certain number of cases, the patients were directly taken to percutaneous drainage, so we don't know that. But among the patients who failed endoscopic treatment were patients who had multiple strictures. So if there are strictures at multiple locations, and usually in recurrent cancer, sometimes it can be quite difficult to treat these patients.
Any issues with limb length as far as it's constructed and make it difficult to intubate?
No, most pancreaticoduodenectomies are constructed with a short limb, and sometimes between an anticolic and a retrocolic approach, you might run into some issues. But the biggest thing that we run into here is when the afferent limb obstruction is from a mechanical twist, or then you can run into a fixed afferent limb, and it can be hard to traverse these.
Okay. Now, this is an uncommon population, and I think Virginia Mason is one of the few centers that can accumulate a cohort large enough to even make sense of. Do you have any suggestions for our readers / endoscopists that encounter this problem, other than referring them to a specialty center?
I think the biggest thing is to think about it. There is very little data on this, and I think once we think about it, then we can treat this more effectively and recognize this. From an endoscopic perspective, I think patients may require a persistent effort with a different kind of an endoscope, with a pediatric colonoscope, or with the use of the new single balloon or double balloon endoscopes. That might give some more effective approach to that. And I think the most important thing is to think about it, and whether they're treated with surgery or percutaneous drainage. I think once we suspect it, most patients are treated quite effectively.
Great. Thank you very much. It's
My
nice talking to you,
pleasure.
Dr. Pannala.
My pleasure. Thank you.